Today's webinar, Diagnosing and Monitoring Ketosis in Dairy Herds, is going to be presented by Oetzel. We're very happy to have him here today to talk about this topic. He is a professor in the Food Animal Production section in the Department of Medical Sciences in the School of Veterinary Medicine at the University of Wisconsin-Madison. He grew up on a beef cow-calf farm in Western Ohio, and he is an undergraduate in veterinary medical, or has his DVM from the Ohio State University. He went on to get his master's degree at the University of Illinois, and then after being an assistant professor at Colorado State University for 3 years, he went back into private practice in Wisconsin before joining the University of Wisconsin at Madison. His current research interests are in applied dairy nutrition and metabolic diseases such as milk fever, ketosis, displaced abomasum, and ruminal acidosis. He teaches veterinary clinical nutrition to the first-year veterinary medical students, food animal medicine to third-year students, and transition cow troubleshooting and applied dairy nutrition to those in their fourth year at vet school. His clinical interests include troubleshooting techniques and the application of herd-based tests for metabolic disease problems in dairy herds. We're very happy today to have Dr. Oetzel here to actually present this topic on how you diagnose and monitor ketosis in dairy herds.
Okay, thank you so much, Donna. It is a pleasure to bring this information to you. We got some new things on ketosis, so we'll get right into it. I think as most everyone here would be aware, ketosis is a disease. It's a metabolic misadaptation or maladaptation on cows. It's an incredible metabolic shift when cows enter lactation, going from a dry period with low requirements, a little bit from pregnancy, and then suddenly ramping up to this tremendous energy draw that they have. And there is an old saying or something that's out there that a dairy cow's metabolic activity produced milk's equivalent of running about a marathon a day. I thought, boy, I better check that out and see if it's right. And looked it up, tried to compare numbers. It's actually not. It's 2 marathons a day. Marathon's about 2,500 calories, and our cows will ramp up toward 4 to 5x maintenance, not just twice maintenance. So these cows do remarkable things in terms of the energy draw that is placed upon them. So if they have a poor response to this negative energy balance, it's going to come. It can lead to ketosis. The mechanism there, biochemically, I think most would be familiar with. But in a nutshell, they have mobilized too much body fat. They cannot completely oxidize that body fat. They don't have enough carbohydrate skeletons to get the job done. So these ketone bodies can accumulate in the cow's bloodstream. She doesn't feel good. She eats even less, and we get into difficulty with that. So why all the fuss about ketosis? Haven't we about this disease for a while? And sure, that's out there. It is the most common metabolic disease in dairy cattle, so that would be the first thing. We'd be looking at an incidence of 20 to 60% in our cows, or a prevalence of about 5 to 30% in the cattle. And right there, I introduced a couple terms which are really important: incidence and prevalence. It's easy to get these two mixed up. You can see the numbers and say that's a lot of disease, but why the difference? So let me just walk you through that a little bit. And even as you read the literature, or as researchers talk, sometimes we get prevalence and incidence mixed up. So we want to make it clear what we have. Incidence is the total number of new cases of ketosis, and that is something that happens over a period of time, usually allowing the animals to go through the entire risk period, which we pretty much would define as early lactation. In order to get the incidence of ketosis in a herd, you have to do repeat sampling. You have to know if she ever got it at all. The average duration of a case of ketosis is about 5 days. And so you have to sample, on 5-day intervals or even less. So let's take a little example here. Let's say we got a herd with 10 cows, And if we repeatedly sampled those cows, preferably at least twice a week, if not 3 times or 4 times, would be great. And we just want to see, did they ever get it? That would be incidence. In this case, we're showing 4 cows that got it out of the 10, and that's intentional because that's average. About 40% of our cows, if we look closely enough, will get ketosis sometime in early lactation. But this usually only happens, this intensity of sampling, only in research projects. The prevalence is how many cases are present at one day. So at one point in time, or if you would like to think of that as being spot sampling, that's something we can do. We can go into a herd, we can subsample the early lactation cows, or we can in fact do them all, and then that would give us the prevalence. Luckily for us, because the duration of ketosis is about 5 days, we can mathematically describe the relationship between prevalence and incidence. And if you know the prevalence multiplied by a number somewhere between 2 and 2.5, that'll get you your incidence. So if you go into a herd and you bleed cows on one day and 20% of those are positive, that would be your prevalence. Then you could infer that the incidence is 40% or perhaps even a little bit more than that. So why do we make a fuss about it? We'll keep working on that theme a little bit. Well, cows that become ketotic generally lose milk production. Not always, but you look at the literature, you'll see losses when they're reported in the 3 to 7% range. I would argue that it's probably more than that they're actually losing, because higher producing cows are at higher risk for ketosis. And when we say we lost so much milk, that's not compared to what she could have or should have given. It's compared to cows that didn't get ketosis using the same cohort. So it's a definite loss. We could probably look at that in a more sophisticated way to see what it really is. It increases risk for subsequent DA, and we've known this for several decades based on some really excellent work that came out of the University of Guelph, that ketosis precedes DA. Then we know once they get a DA, it makes the ketosis work. So look at the literature, you'll see increased risk of DA with ketosis in the 3 to 19-fold greater amount that they would get. It's a small prevalence disease, so those risk ratios or relative risk, whatever they might be, can be very different from study to study. There's one study that I was a part of with Dr. Jessica McCart, and we saw increased risk of culling in the first 30 days of lactation was 3 times greater for cows that became ketotic. A lot of studies have looked at decreased reproductive performance with ketosis. In general, we're looking around that 1.2 to 1.7 times less likely to conceive at first breeding. You don't usually look at outcomes after that. I think that number is going to be on the smaller end, perhaps to nil, if the herd is doing ovulation synchronization. Because what happens with ketosis is sometimes cows do not cycle as well. I'd say it's probably pretty fair that they don't, or they may not express estrus as well. And with ovulation synchronization, you somewhat take over both of those functions. So I'm not saying if you do off-sync that it's going to absolutely be no effect, but it probably does blunt that repro effect of ketosis a little bit. So if we can agree that it's important, let's talk about measuring and monitoring this thing in the herd. So beta-hydroxybutyric acid, or BHBA, is the de facto standard for defining and measuring ketosis in cows. It's a stable compound. It is very easy to measure from an analytical standpoint. You can do it in serum, plasma, whole blood. You can do it calcite. Calcite is the largest molar quantities of any of the compounds we look at for ketosis. So now we got a disease that we can characterize with numbers, because we can do BHBA, and we can quantify this with a lower threshold where it starts, even an upper threshold where it crosses into a more severe, what we might call a clinical ketosis. So we hit on that lower threshold first. The units are usually millimoles per liter, and 1.2 is the threshold we most commonly use. As you look at different studies, you'll see slightly different thresholds. And that depends on the outcome, the population of cows, when they did the testing, at what particular days in milk, and how they decided what was the bad outcome and when did that bad outcome start based on the blood level. So yeah, they're going to be different. In general, we're looking at about 1 to 1.4 as the range. And people really like to want to change these thresholds or cut points. There's nothing else to argue about them. And I would say there's little real value to it. There is value to us as an industry getting on one and staying with it. And 1.2 has been the one that just seems to make the most sense, is used a lot. I encourage folks to stay with that. That's the lower threshold. What about this upper threshold? What if we have a cow that's really bad? Shouldn't we try to characterize that? And we can. It's sort of by default, 3 millimoles per liter or higher has become this upper threshold where cows should show clinical signs, or we might say that those are worse than others. And that's very, very soft, very subjective, but it's kind of the best we have. What would those clinical signs be if we're expecting to see clinical issues as they go over 3? And that's a little unpredictable whether it'll really start there or not. But the signs would be decreased milk yield. Well, we're in a time where milk is very volatile. It should be going up. Maybe it's just not rising fast enough. It's off what it should be for that cow. Are we looking at monthly tests? Are we looking at daily milk weights? Are we just subjectively assessing yield in the parlor? Very difficult thing to do, and the level of intensity we would bring to that would vary. Cows with ketosis, particularly if it's higher, are supposed to have a dull appearance or show depression. That's totally in the eyes of the beholder. It's supposed to have decrease in motility. Wow, I think we sometimes see that. It takes a long time to listen, and practically that gets us nowhere as we're evaluating a large number of cows out in the field. Rectal temperature will be normal. We have to be careful not just to call any cow who looks a little sick or down in milk to be ketotic if she doesn't have a fever. There needs to be some other criteria brought to it, but we would expect it to be normal. And if we have a situation, particularly with our tie stall herds component feeding, they might notice the cows had a better appetite for hay compared to grains or silage, or at least just know which cows I'll feed. And that's something that's hard to do in group settings. We can do it a little bit, and usually we would see some appetite depression, particularly relative to milk yield. My big point is all these clinical signs are subjective. They're often missed depending on the intensity that the herd brings to it. But we have to deal with this clinical, subclinical notion. Somehow it's just part of our jargon. So in general, we say, quote, subclinical ketosis is 1.2 to 2.9 millimoles per liter of blood BHBA. We'd say clinical is 3 or higher. Perhaps my preference would just be to talk about ketosis, which would be, by definition, hyperketonemia, high blood ketones. In that case, it would just be anybody over the 1.2. Looking at data I've collected in the past, we're going to have maybe 3 to 5 or 7% of our ketotic cows in that clinical category. Varies by herd. Some herds rarely put cows up that high. The herds that have more trouble might have quite a few, pushing toward 10%. So how are we going to measure this blood BHBA? So researchers, we use laboratory tests, we use serum, that's our gold standard, put it on a fancy machine. But on-farm ketosis testing needs to be Cowside. So a big part of this seminar is to get through those tests and to understand which ones are out there. We've got options. It can be blood, it can be urine, it can be milk. We also have options on our ketone bodies. It can be beta-hydroxybutyric acid, BHBA, it can be acetoacetate, or ACAC, or it can be acetone. And all those can figure in. As we already said, it's mostly BHBA, but you'll see these other three, the total of the 3 ketone bodies popping up now and then, and for different body fluids, we may use different ones. And talk about the first Cowside test is this sweet smell on the cow's breath. That's acetone, one of the ketone bodies, perhaps other compounds. I don't think it's just acetone. I think most all of us can smell that. But only certain individuals really are good at doing this. I'm not one of those. I never was good at smelling ketosis, stick my nose right in their nose, and might or might not get it. Even people that are good at this and claim to have the ability, they can smell it sometime. When tested, they're about 50% sensitive in identifying ketotic cows. And that doesn't help us very much at all. That's not a useful test. So if they're positive and the person has a nose for it, they probably are positive. The issue is, what about if they're negative? Because at only 50% sensitivity, you don't know. So I just defined, or at least been talking about, another epidemiological term. We did incidence and prevalence. Now we get to do sensitivity and specificity. So we're going to doodle here a little bit and draw some things on here. This is your gold standard up at the top. We're going to make a 2x2 table. The gold standard is the actual laboratory test. So they were either positive or negative to that. And here's our Cowside test over here. These are test positive and test negative. Could be blood, urine, whatever. Those are the things we have. Now, if we want to do sensitivity on this, we're going to look just at the ones that were gold standard positive. And if they were gold standard positive, we hope they were test positive. If they weren't, they're what we call a false negative. The sensitivity that results out of that is looking at the true positives divided by the true positives plus your false negatives. So it only deals with the ability to detect cows that are truly ketotic. Easily the most important part of this ketosis detection. If the cows are negative on the gold standard test, we would hope that our test, in fact, would have identified those as negatives. That would be our true negatives down here. Could have had some false positives. If we look at the relationship of the true negatives divided by the true negatives plus false positives, that's what we call specificity. Not as important with ketosis, because treating cows that don't need it isn't as big a deal as not treating cows that do need it. We have a test that causes little to no side effects, very little danger. It's not an expensive treatment that we have to apply. So we really want tests with good sensitivity. You're going to hear me talking about that a lot. So we already said that the smell of the breath is not a good one. So what are some other ones? We can use a urine test. This is the most common one, the Keto sticks. These are pretty inexpensive, around 20 cents each. We do have to get the urine sample. That's easily the hardest part of this. And in my experience, if you really need a urine sample from that cow in that fresh pen in a reasonable amount of time, you're going to get 40, maybe 60% of them to actually urinate. That's even if you're pretty good at it. If I was doing it, it'd be less than that. Once you collect the sample, apply the urine to the strip, please read the directions, dip and read the strip within 10 seconds. Leave it on too long, you can create some false positives. So this big issue is the low percentage that will urinate. Passing catheters, doing vaginal exams is impractical unless you're a veterinarian. If you get frustrated, just touch the strip to the vaginal wall. That doesn't really tell you anything. So if you're going to use this test, you need a plan for cows that don't urinate. And you need another backup test to go along with that. Let's say you do get your urine sample from a cow. It has a scale that we would be reading, and I'm sure most of our listeners are familiar with that. We're going to call them ketotic starting at small. So it's a 15 milligram per deciliter. This is acetoacetate that we're measuring in the urine. So 15 or higher is going to be ketosis. And this is going to have modest sensitivity and modest specificity, about 80% sensitive, 95% specific. You do it right, you're not going to get a lot of false positives. A little worried about the false negatives, not terrible, but not the best either. So that's a test that's been around, is one that we use. There is a milk test. In fact, there are a couple different ones there. The first one I'm going to talk about is a nitroprusside powder. Occasionally you see that in tablets in other parts of the world. You look at the literature on this, it varies a lot, but it averages out 35% sensitivity, very good specificity, but that 35% sensitivity is a stopper. We can't use this as the sole test because we're missing almost 2/3 of our cows. There are some herds that use this, and the problem is most of them come up negative. Here's one, they just mix up a little bit of this powder with some milk on a gloved hand, and maybe put it up on the cow's hip. You have to wait 2 minutes to read it. There's a negative. And my problem is that doesn't tell me much. She may really be positive. This would be a positive response here. It just turns a little bit pink. And it's not a vibrant pink or really come out and get you. Color change is pretty subtle. You better have good light to be able to see that. There's another milk test. There's the Keto test strips. These are about $2.50 in the U.S. market. Price may be coming down some more on those. Here's a dip and read on a milk sample, but with 60 seconds later. On this one, this actually measures BHBA. It has different cut points. It looks similar to the urine, and we're going to use that 100 micromoles per liter as the cut point. There's a lot of literature on this. We run in the low 80s on sensitivity and in the low 80s on specificity. So we're doing pretty well here. We're going to miss 15, 20% of our ketotic cows. Maybe she'll be ketotic the next day. I don't know if we've done those kind of time sequence evaluations. But a little worrisome to me to be missing some ketotic cows, although hopefully they'll come up later. There's another company that has the same technology. On this one, Porta BHBA, they have a test strip around the same price, same criteria. There's one published study I'm aware of on this, very similar sensitivity and specificity up in the 80s on both of those. So this does pretty well for us. The blood really is the best, and we do have this Cowside option. So we're showing here the Abbott Precision Xtra meter. This comes out of the human market. It's a handheld meter. As we introduced this to the industry, not many people were familiar with it. Now we got lots of people very familiar with it. And over 1.2 on the meter. We're going to see sensitivities running 90% or higher, and it depends on which study. There are multiple studies out there now with very good specificity. So as we think about Cowside tests for diseases in general, this blood BHBA test for ketosis is probably the best one we've ever had and may ever have as a Cowside test. We're just not used to getting up into the 90s on sensitivity and specificity with that. So we've used this for cow level diagnosis for sure. For herd level monitoring, it's excellent for that. We've even done herd level research with this, but we do repeated testing on individual cows. For small research studies, we have to go back to the serum for sure if we want to measure subtle changes. We're just looking at big picture ketosis. This test can be used even in research studies, which is great. The problem on this has been availability. And I'm sure some people out there have already been groaning as soon as we start talking about this test. It was available for veterinarians through veterinary markets, getting to producers around $1.40 a strip. And a little less than a year ago, Abbott decided not to do that anymore, not to do the veterinary pricing. We can still buy all we want at the human price. The human marketing channels can hit you at least $4 to $6 a strip on the U.S. side. What we have had some people doing, it's not terribly convenient, but Canadian, even other sources overseas, this is through human marketing, but they sell them a lot cheaper in other countries. So a lot of people are getting it into the U.S. at around $2.50 a strip. But doing this kind of import-export work is not fun. It's certainly legal. It's just a diagnostic test. We're not running drugs across the international borders, but it's a little bit harder. So there's been thought that we really need something different. Several companies are stepping up. This is the only one I've seen clear data on so far is the Nova meters. So Nova Biomedical makes a Nova Vet, which is a specific bovine calibration. These are about $3.20 a strip. Nova Max is a human version. Interestingly, cheaper. Doesn't look like it works quite as well. So we're just going to talk about Nova Vet a little bit. I have evaluated these in a couple of small trials. The first thing that's happened with this particular product, there's been a lot of strip errors. We didn't have strip errors, and we still don't with Precision Xtra. But this one here, you can load up a strip with blood, and the meter just gives you a message, strip error, and you have to go get another one. And because they're more expensive, that's very awkward. One of the things we've seen that you have to do is keep blood off the top of the strip. So as you load these, you want it to be allowed to aspirate the blood up through. It has to go through those 3 sample wells and be done. If you just squirt a lot of blood on the top, you may get one of those errors. So that's been frustrating. Even if you do it real carefully and let it aspirate up, you'll still get some strip errors. And 5% wouldn't surprise me, maybe even more. And if you're not careful, you can lose 10 or 15% of these strips. The other thing with this one, just a little aggravating, is they actually made the meter upside down, because we would normally hold it with the strip down, and in that case you can't see the reading unless you can read upside down. So you have to flip it over, and so it's not laid out the same way Precision Xtra is. And as we've done a couple field trials, we're getting pretty modest sensitivity and specificity in that 80 to 90% range, not where Precision Xtra is. So there's one study published in abstract form from Minnesota, to be fair, where they were over 90% on sensitivity and specificity. We have not gotten that in the work that we have done in smaller kind of pilot studies. But having some difficulty recommending this one, if you're expecting it to be the same as Precision Xtra, it simply is not. It's as good as the milk BHBA test, so it's not that problematic, but just don't expect it to be the same. There's at least 2 other companies working on Cowside blood BHBA test. I think in a year or so we'll know more. We may have better marketing on Precision Xtra in a while too. If you're doing this and collecting these blood samples on whatever meter that you're using, you want to get that blood out of the tail vein, not the milk vein. We don't want to be sticking needles in there. Plus, it actually changes the BHBA concentration compared to blood that's circulated through the rest of the body. So the results are not right. Pardon me there. I just get usually I buy 3 ml syringes with a 22 gauge 1-inch needle attached for about 8 cents a piece. Definitely using new needles, new syringes on every cow, so we're not spreading any more leukosis. Bleeding cows and lockups, even in tie stalls, you need such a small amount of blood that this really works pretty well. Usability on the meter is very good. Just make sure you put the strip in before you apply the blood. Keep the meter and strips warm. These are enzymatic reactions that are happening on the strips. They're very temperature sensitive. So we just keep the strips on an inside pocket, and then we're applying warm blood to it out in the barn. So it works all right. So there's our Cowside part. I want to finish up with using our monthly or DHI-based ketosis testing and talk about some of the options there. We even have some in-parlor systems now that can do parts of this. And I think this is an interesting place. Nothing is going to supplant Cowside blood testing. Is being something that's very accurate and it's possible. But this is something that I think we're going to see more of because of the practicality of it. So starting with looking at milk fat to milk protein ratios. Again, some nice pioneering work that came out of the University of Guelph, where they learned that ketosis does indeed increase milk fat and decrease milk protein at the same time, making it appropriate to look at the ratio because both are affected. And milk fat protein ratios, I just notice I got it here on my slide, should be greater than or equal to 1.4 are suggestive of ketosis. Or sometimes the symbols that we make on slides don't cross from one program to another. But anyway, it should be greater than or equal to 1.4. That's gone up, protein has gone down. We've used this for probably a decade now. It's a very general herd inference, not necessarily as a cow level test, but herds that have a high proportion of cows with a high fat protein ratio do tend to be ketosis problem herds. So now you're using your monthly DHI test samples to get some inference on how the herd is doing. I'm going to show you some preliminary data that we have from some field studies that we have done looking at cattle where we collected blood, and so it's going to be serum BHBA done in the laboratory compared to the milk fat protein ratio on those cows. Now what we see here in this chart is typical anytime we go looking at how tests work for ketosis. We don't have a very even distribution of BHBA, so we have just a very few high values. Most of the cows are sitting down here well below this threshold of 1.2. But we can only, do the best we can with these imperfect data sets. And I think there's around 500 animals in this one. It's just a preliminary set. So I want you to think of this for teaching purposes and to see, milk fat protein ratio on individual cows indeed goes up as serum BHBA goes up. But is this a really good test at the cow level? The answer would be no. The R-squared is only 0.9. We're only explaining 9% of that variation. And you see, the real big problem here is a lot of false positives. Cows with very high fat protein ratios that, in fact, are not ketotic at all. So this one would cause you to over-treat, potentially, if you're using this an individual cow-level test. Thankfully, it looks like most of our cows, at least we're up over about 2 blood BHBA, were flagged, but a very large number were also flagged. Remember that the cutoff's considered 1.4 here, so a very large number of cows would be flagged as ketotic that in fact weren't. Our overall accuracy of this, if we're using it as a prediction, and that's accuracy is just the number of cows it was correct on, where it said, she was ketotic, over 1.4 or not. So it allows errors to go either way. It was only 68%. So that's not real good as an accuracy figure. So the next approach that we've seen coming through on these monthly DHI-based testing schemes was to actually look at milk ketones. There is new equipment that is available to a lot of DHI testing centers that can look at milk BHBA and or milk acetone. And, pardon me again, I've done work on this, and a lot of this is my collaborators' work, Dr. Heather White in the Dairy Science Department at UW-Madison. We started into this, and the first thing we did was look at the literature, saw almost no agreement at all on what the cut points were, especially for milk BHBA, and where cows were negatively affected by that. Saw pretty modest accuracy in the data that was reported. So here's that same data set. We're going to talk about blood BHBA versus milk BHBA. And it didn't do too well. In fact, our accuracy is only 62%. There's the R-squared at 0.9. And it's just missing an awful lot of these. There's a very weak relationship, but not something that gets us very excited. Certainly some herd inference here, probably. There's a cow level test. We would not think of this as being very good. Milk is not an excretion route for BHBA. And it's just not something that I think we're able to find, just a lot of inference on what's going on here in these cows. Milk acetone is another one that can be done. And so, this equipment, this DHI processing center can be calibrated to do that. Our accuracy is gone up, the R-squared is still pretty low, but every research in the literature that milk acetone is a little better than milk BHBA. Our data would support that, but still not really good enough. So Dr. Reitman approach this. He said we need a better way to predict blood BHBA in the past. what we've done is combining testing information with developing all of the information about that cow. And potentially more than just one cannabis or more than one set of Xtra off the milk sampling.
Gary, your voice is trailing off some.
Yep.
Sorry to interrupt.
Yep.
There.
That's all right. Well, we'll get through these last slides, and I'll do my best, okay? So, anyway, this has been commercialized through AgSource. It is Keto Monitor. We continue to refine this, but I want to show you a little bit about how we got this thing started. Our initial data set was 550 animals, 10 farms. There were 2 jerseys. We learned very quickly that the jerseys were going to be a separate prediction, and we just didn't include those in what I'm going to show you here. We did later develop, and they have commercialized the jersey model as well. So lab BHBA was always our gold standard. We looked at basic cow information, which would be lactation number, days in milk, and we looked at everything we could get off that milk sample analysis. Fat, protein, BHBA, acetone, NUN. Even now, we're down to the individual spectra that are available there. So we did our regression models for this, trying to predict using all the data. We learned quickly that the models are going to be different for first lactation versus 2+, for somewhat earlier days in milk than later. We did this out to 20, and as I already said, the Holsteins and Jerseys were going to be very, very different. So our modeling scheme looked like this. We break them down by first versus 2+, then by the lactation group. Here's the R-squareds. We're up to 0.7, 0.6, 0.5, way above the 0.9s, 0.09s, excuse me, that we saw. Now we're predicting 60, even 70% of the variation in that. And the accuracy jumps up into the 90s for heifers and the 80s and higher for cows. So now we're back to where we were, an individual cow blood test, or individual cow milk test. And this is just coming off a monthly DHI report. So this is promising. This is useful for things that we can do for herd level testing. We are still not sure that this is particularly good. It's for cow level testing. Better than nothing, but not great. So if I would put a summary on this, and Dr. McCart's going to talk a lot more about it, but for herds, let's implement some form of testing. Your testing designs need to be flexible. Knowing your prevalence allows you to optimize that. I would say that going into this, please be aware that herd prevalence is not static over time. A herd isn't a 5% or a 10% or 15% herd. That can vary. So I'm going to show you data here from a herd that was doing blood testing. They were doing about 20 cows every week, and I pulled my results, and this is what we got here, and you see it varies over time. And this is the same herd without key management issues. And you know it goes up and it goes down. I'd sure like to learn more about why herds change like that, but it's certainly possible. So that is my introduction for you on this, and we'll turn it back to the moderator. Not sure what's going on with our sound issues. I've got a really bad code, doing the best I can here, but we're done with this formal part, and I'll turn it back over to Donna.
First question is for Deborah. She asked if what's the difference between breeds as far as they're concerned? Are there can different breeds tolerate different beta-hydroxybutyrate levels? And is that level 1.2 used for all breeds or just specifically for Holsteins?
Yes, right now we should be fair and say that is Holstein data. We probably have a lot of Jersey data, but we have not gone into seeing how those BHBAs affect production outcomes. So we made the assumption that it's the same across breeds, but we don't know. And I think it would be fair to start at 1.2, but also to look at that, and if you got a different breed, to say, well, don't know. I would rather overtreat than undertreat cows, though. And I would be reluctant to just arbitrarily move it up. I'd rather be a little bit safe. Who knows? Maybe it's 0.8 for a different breed. Stay tuned. Give us a few years, and we'll probably have something to report on.
One of the things, Gary, that's always a challenge is for farmers to understand if they have a problem in their herd. Obviously, they look for clinical signs, and as you went through, those are very hard to diagnose. What would be your recommendation to some of those farmers? Because a lot of times they don't think they have a problem, and in reality, they might have a problem.
Yes, and we've seen lots of, we'll say, quote, blissful ignorance on the part of producers about this disease until we go in and screen the herd and check. And usually doing the blood testing, especially because we have these Cowside tests, you can usually make your point pretty quickly and pretty easily. I have had really no luck just looking at herds, looking at cows, looking at records, and saying this is a ketosis problem herd or this isn't. You have to test them. So I would encourage people to do something and not to assume just because they don't see fulminant clinical cases that they're okay. They may be surprised. And the next word of wisdom would be repeated testing within herds, because it can vary. You can catch them, it doesn't vary day to day or week to week, but perhaps month to month it does. So they should be tested repeatedly and not assume everything's okay.
I think one of the things that we've learned over time with all these metabolic disorders is it may not be the clinical ones that are getting you, it's the subclinical ones, the ones you don't see.
And that's an excellent statement. And what you see is so much in the eye of the beholder anyway. So, yeah, we absolutely emphasize that, for most of our producers, just call them all subclinical. And the nice thing, a short presentation didn't show you everything we have, but when you do early detection and early treatment, they get better, faster, you get more milk, you reduce the risk for DA, you reduce the risk for herd removal. It's a wonderfully effective, not perfect, but very effective treatment.
Thank you very much, Gary, for making this presentation for us.
Well, you're welcome. It was my pleasure.